Good morning. So my name is Randy Pearson. I'm actually one of the only current faculty that's still with Michigan State University. I have been working on this course for, I think, 14 years. My full-time jobs, though, are at Michigan State, where I'm a professor in the Department of Family Medicine. I work with our residency program at Sparrow Hospital. I'm the Senior Associate Director for that program. I'm also the Interim Program Director for our Sports Medicine Fellowship. I work 30% of my time in the Dean's office, where I'm the Assistant Dean for Medical Education, or the DIO for our sponsored residency programs. And in my spare time, I am the team physician for Michigan State's football team, which I've done now for 25 years. So that's kind of spare time. So I'm probably a 1.5 FTE employee, which makes it nice for me to get away to teach this course. So the first three lectures I'm going to give to you are on orthopedics and sports medicine. We'll start out with the first half hour talking about general sports medicine topics that we as primary care physicians see in our offices on a regular basis. We'll do a little bit on imaging during that first half hour, and then the second two sessions will cover more orthopedics. So we'll cover the upper extremity in the second half hour, and in the third lecture, which is 45 minutes, we'll talk about the spine and lower extremity. So here's a question for you, and we'll have questions interspersed in all of our lectures. What ends up happening is you don't know the answer to the question, but we cover it on the subsequent slides. So just to give you an idea of where you're at going in. So here you have a 12-year-old male that comes to your office for a pre-participation exam. His previous medical history is unremarkable, except he had a testicle removed for cryptorchidism. So which of the following sports would you recommend he not participate in? Tennis, basketball, football, diving, or no restriction. So we'll talk tonight about how to take these questions if you don't know the answers. You think about this one, and what's the risk? So the risk is that he has only one testicle and he'll lose the other one. So you can go down the list and say, well, which sport is likely to cause that type of a problem? And you know it's not tennis, unless you happen to get a bad shot right in the groin. Basketball, probably less likely. Diving, no restriction from that. So you're left with football, which is the only collision sport on the list. And that's actually the right answer. And we're going to talk about this in a second because this is not an absolute contraindication anymore. So we all, as family physicians, do pre-participation exams in our office. We like to think that a pre-participation exam is done so that it makes it safer for an athlete to participate, so we can predict whether or not they'll get an injury. Actually, that's not true. So there's very poor positive predictive value of a pre-participation exam with respect to subsequent injury, although there is one exception, which I'll talk about in a second. So the one thing we want to do, though, is we want to identify problems that we can fix and then allow the athlete or the prospective athlete to participate safely. Doing it far enough in advance gives us an opportunity to rehabilitate problems that we may discover. And then the last bullet in this section is important. If you think about these kids, most of the time they don't come into your office for anything. And so this is an important opportunity for us to establish the gateway to the primary care system, not just to the sports medicine system. We can do things like talk to prospective athletes about drug use, alcohol use, safe sex, cigarette smoking, get them up to date on their immunizations. So a good opportunity for us to see this patient population where we normally wouldn't see them very often. So how often and how frequent do we do these exams? Well, a lot of this depends upon the regulations in your state. Now, for sure, you want to do the exam at least far enough in advance so that if you identify a problem, you can go ahead and rehabilitate that problem. How often is another question. So in Michigan, the Michigan High School Athletic Association requires our prospective athletes to have an annual exam no earlier than April of the year prior to participation. So they come in every year. And that's actually probably a good thing for skeletally immature athletes because things happen over time that you can actually look for in these students. At the college level at Michigan State, we do an entry-level exam for every prospective student athlete. And then we will only do an annual update, which is usually a paper form, which goes through their problems that they had for the previous year, share with our athletic trainers what type of rehabilitation needs to be done for those. For older individuals who come to your office wanting to participate in exercise or sport, probably an initial level exam and then only subsequent exams as needed if they have symptoms. So some of the things we want to cover on the pre-participation exam are things like previous head injury. So there's a lot of talk about concussion, and we'll spend a few slides on concussion in a couple minutes. The one thing that's important about previous head injury is that we can identify unsafe behavior that collision sport athletes participate in, like lowering their head when they make a tackle, and hopefully help prevent those problems in the future. Previous history or a family history of sudden death before the age 35, mainly looking for arrhythmogenic problems, familial arrhythmogenic problems, as well as hypertrophic cardiomyopathy. So both of those would be important things to determine early on so that we can either treat the arrhythmogenic problem or disqualify the athlete with the hypertrophic cardiomyopathy. Any shortness of breath associated with exercise, looking for exercise-induced asthma. We'll talk about this again in a second, and we'll revisit this in our allergy chapter, I think with Dr. Frenchik. Amenorrhea. So any female athlete who has amenorrhea, we want to identify potential female athlete triad, and we'll cover that in a second as well. Again, an opportunity to catch up our student athletes in their immunizations, not because there's actually any inherent risk in participation with development of immunization preventive disorders, but again, it's a good opportunity for us to catch them up on their general health. And finally, believe it or not, adolescents don't always tell the truth. Especially they don't always tell the truth when their parents are around. So you want to give the athlete an opportunity to discuss problems that they may be having with you independent of their parent. So do a history while the parent's in the room, have the parent leave for the physical exam, and then ask the student anything like drug use and safe sex and that sort of thing. So there are some pearls with the physical exam. Now you're going to do a general physical examination, but some of the things that you want to look for are, first of all, heart murmurs. Understand that the murmur of hypertrophic cardiomyopathy is exactly opposite the characteristics of a functional murmur. So hypertrophic cardiomyopathy murmur will increase with Valsalva and decrease with squatting. We don't have to do a complete orthopedic full musculoskeletal exam. We try to do a focused exam, and in fact at Michigan State what I do is what we call a 12-point musculoskeletal screen, which I'll show you what it is. I have the athlete stand up, and I have them look down to the floor, look up to the ceiling, touch their left ear to left shoulder, right ear to right shoulder. This is actually an opportunity to see how well they follow directions too. I can't tell you how many college athletes, when you say touch your left ear to your left shoulder, will go, or right ear to right shoulder. So anyways, watch how they follow directions. I have them shrug their shoulders up with applying a little bit of force on the shoulders, bringing their arms out to the side, up over their head, straight forward, and then down. Then I have them bend over and touch their toes. Athlete who can't touch his toes indicates that they have short hamstrings that predisposes them to hamstring strains. So watch for that sort of thing. Then I have them stand up on their right foot, stand up on their left foot, and then I have them squat down and walk. Like that, 4 steps. And that's it. So now I am qualified to play football for Michigan State University. I'm sure Coach D'Antonio is really discouraged about that. Tanner staging. So it's important to assess the prospective athlete's musculoskeletal maturity. And this is the one area where this actually may be predictive of future injury. So there are studies in the pediatric literature that have shown that individuals who are 2 Tanner stages discrepant from the rest of the people in their group. So for example, if you have a Tanner 2 playing football with Tanner 4s, the Tanner 2 has an increased risk of musculoskeletal injury. Not that you would disqualify the individual, but certainly you would mention that to the parent. And then we really don't recommend any other screening. A lot of controversy out there about screening EKGs, screening echocardiograms. A lot of the literature around screening EKGs came from an Italian study where they actually found a decrease in sudden cardiac death when they screened individuals with EKGs. So here's a couple caveats with that. First one is they were looking only for the specific type of sudden cardiac death that's caused by an arrhythmogenic phenomenon. If they identified that on EKG, they disqualified those athletes and then they decreased their risk of sudden death. but they only decrease the risk of sudden death to the level that actually is currently present in the United States. So they had a high prevalence of arrhythmogenic issues in the Italian population, which we don't have here. And so that kind of skewed that data. That having been said, International Olympic Committee recommends screening EKGs. Echocardiogram, another good question, but we found that the bang for the buck with echocardiography is really not that great. It's unusual with a trained family physician that an echocardiogram will discover a clinically significant problem that we don't first identify on physical exam. All right, here's the American Academy of Pediatrics disqualifying conditions. There's your question. Absence of one of a pair of organs. The American Academy of Pediatrics recommends a qualified disqualification for collision sports for this problem. Qualified means that you can counsel the student athlete and their parents about potential risks and use appropriate means of protection. So for example, if they're missing an eye, in football, if you use a helmet shield, that will prevent an injury to the other eye. Next one, uncontrolled chronic disease, and the key word here is uncontrolled. So when I was in high school, I was a student athlete. I played golf, and that's supposed to be humorous. Student athlete played golf. And back in those days, we used to all go down to the locker room and line up in a row and in our underwear, and the doctor would just go down the row and examine every kid. How many of you of my same vintage have gone through that process? A few. So here I am standing there. Doctor comes by, checks my blood pressure. I have elevated blood pressure. Well, there's a surprise, right? I had to run down to the locker room, get undressed, and then stand in this line with these other kids. So he disqualified me from golf. So I went to my family doctor, and my family doctor checked my blood pressure. It was normal. He said, your blood pressure's normal. Had it been elevated, I would have prescribed golf. So again, uncontrolled is the key word, and also think about the context that athlete is going to participate in. Hypertrophic cardiomyopathy, an absolute contraindication to participation in sport. And then finally, you're doing this far enough in advance so that you can rehabilitate problems that you find. So you can do a temporary disqualification, have the prospective athlete come back, and then clear them at a later date. All right, a little bit on exercise-induced asthma. This is a clinical diagnosis for the most part. When you ask the individual how well they're able to keep up with their fellow students, the ones who can't keep up because they get short of breath, you suspect of having exercise-induced asthma. Pretty common problem, up to 20% of the general population, and 80% of asthmatics have an exercise-induced component. So we don't have to do things like exercise spirometry, although you could do that to confirm the diagnosis. Most of the time what we'll do is we will see an individual, says they can't keep up because they get short of breath, and then we will prescribe either a short or long-acting beta agonist, depending upon their sport. So if they're an endurance athlete, like a cross-country runner, using salmeterol actually is more effective than using albuterol because it survives for the full length of the activity. More important with marathoners. We can also use chromoglycates. So chromalin and netochromol, both are really effective. And the nice thing about these drugs is that they don't have the tachycardia side effects that the beta agonists do. Very low side effect profile except for a metallic taste in the mouth. The other thing that's important with the chromoglycates is because they're mast cell stabilizers, you need to make sure you give enough of the medication. So it may take up to 8 puffs of chromalin, for example, at a time to reduce the symptoms. And you also have to do it far enough in advance of the activity to make sure that the chromoglycate is on board. Now, I talked for a second about adults who want to come in and start an exercise program. We know how important exercise is for overall health and well-being. And so sometimes it's important for us to create a medical association with exercise to improve the patient's understanding of the importance. So what we do then is we write this on a prescription pad. You'll write on the pad the amount of exercise, the intensity of the exercise, how often they need to do it, and how long they need to do it. So just basically aerobic exercise, put down their target heart rate, which is calculated as either 200 or 220 minus the patient's age, reduce that by a percentage if they have chronic disease that might affect their exercise, and then you just write out the prescription. Aerobic exercise, 3 times a week, 30 minutes a session, target heart rate 130. Give that to the patient, and that legitimizes their exercise as a medical treatment. You also can talk to patients about normal activities of daily living being part of their exercise regimen. So for example, if they run the vacuum cleaner in their house, that's exercise. Be careful when you've got the male patient in your office with the wife in the chair telling them that they should be doing more vacuuming. All right, this slide should be titled, Athletes Are People Too. So we have a high incidence of drug use in student athletes, but it is lower than the overall incidence of drug use in the general student population. There are prescription medications that are used for legitimate causes that are on banned substance lists. So for example, using beta agonists in swimmers is with caution. Using beta blockers in biathletes is banned. Now why is that? Why would a beta blocker be banned? Well, we just saw the Winter Olympics. Biathlon is a combination sport of cross-country skiing and riflery. So the athletes will go along cross-country ski for a while, and then they stop, and then they have to pick up a gun and shoot a target. If they're on a beta blocker, it lowers their heart rate so that when they're aiming, the gun is not doing this with every heartbeat. So that's really important, and that's why the International Olympic Committee bans beta blockers in that specific population. So if you're taking care of an elite athlete, whether an Olympic level athlete or a collegiate athlete, use the resources of the U.S. Anti-Doping Agency for Olympic sports and the NCAA for collegiate sports to determine whether or not legitimate prescription medications are on the banned lists. A lot of ergogenic aids like anabolic steroids are used, and we see this in wrestlers, we see it in bodybuilders, we see it in some endurance athletes. Make sure you counsel athletes about the adverse effects of anabolic steroids with respect to a whole host of metabolic problems in the body. Athletes use street drugs. Important thing for street drugs is that, first of all, they can habituate. Second of all, they place both the athlete and their teammates at risk because of decreased reaction time and decreased attention. So we don't want athletes with street drug issues participating in our team sports. Last one is erythropoietin. So erythropoietin will increase the red cell mass and increase the oxygen carrying capacity of the blood. So this is a value for endurance athletes. This is why cyclists use erythropoietin. Works for that purpose, increases sludging of the red blood cells, and so you have things like seizure disorders, stroke, and hypertension as a result of that. So again, discourage using erythropoietin. A lot of nutritional supplements are used. Big one is creatine. Creatine is used because it works. How it works is basically it affects the water metabolism moving in and out of skeletal muscle cells. So it will increase performance in power sports. So things like weightlifting, wrestling, offensive and defensive linemen in football, all can benefit from creatine. The side effect is that because it affects this water movement, it also will increase the risk for developing dehydration. And we've actually had student athlete wrestlers who have died when they're trying to make weight while using creatine. So really try to discourage using creatine in your athlete population. Protein supplements are again commonly used. The most common thing that happens with protein supplements is that it increases the value of the urine because most of the protein actually just gets excreted in the urine. One of the problems though with protein supplements is they are not regulated like normal drugs. And so we've had cases at Michigan State where student athletes have tested positive for banned substances when only using protein supplements that they bought at places like GNC. So you'd think they're legitimate, but they're tainted with things. And so we will generally discourage the use of protein supplements unless the protein supplement has been adequately evaluated by our laboratory. We talk sporadically about herbal medicines in this course. We really don't understand how herbal medicines interact with other drugs, and so we generally will discourage their use in our exercising population. All right, so we talked about getting a menstrual history on our female patients. The reason why we want to do this is because of the female athlete triad, which consists of amenorrhea, anorexia or bulimia, and osteoporosis. Because of the potential lifelong bone loss effects of this syndrome, we want to assess every amenorrheic athlete for the likelihood of eating disorders. And we do that by looking for things like sores on the corners of their mouths or loss of enamel in the teeth, which would indicate excessive vomiting. And we'll talk in a second about when we take our dietary history to make sure we assess the amount of calories that the individual takes in. Amenorrheic or eating disorder patients often will tell you they take in a huge amount of calories and yet their BMI is 15. And so that's someone who you would suspect for having an eating disorder. Again, bone loss in these patients is lifelong, and so it's important for us to make this determination early on so that we can effect appropriate treatment. Other things like stress fractures and infertility, as well as cardiac arrhythmias, can happen because of the disrupted metabolism in these patients. So treating this is a very difficult problem. It requires a concerted effort by the primary care physician, by a nutritionist who's used to dealing with eating disorders, by psychologists who are used to dealing with athletes with eating disorders, and sometimes with dietitians as well. So all sorts of different people need to work together on these problems. One of the biggest topic areas in collision sports is the area of concussion. And when football starts in the fall, you will see a plethora of advertisements or articles on the local news talking about effects of concussion in our collision sports. Now, when I started in sports medicine many years ago, we used to grade concussions based on a scale that was developed by Dr. Robert Cont'd, who's a neurosurgeon at Harvard. And in this scale, what happened was you could assess an individual with their current symptoms, and then you could tell whether they had a grade 0, 1, 2, or 3 concussion, which would then determine how long they would stay out of action. And you will see individuals go to emergency rooms now and come out with a grade of their concussion. You can't grade a concussion until after the patient's symptoms have resolved. And so now we know that every concussion is different. You can't prospectively determine how long it's going to take for an athlete to recover. You can only watch them over time and see how long it took them to recover. So the current recommendations now are the 5th International Conference on Concussion in Sports, which happened in Berlin in 2016. These recommendations have also been adopted by the American Academy of Neurology at their last meetings. So here's a consensus statement from 2017. Well, this is a complex pathophysiologic process that's induced by traumatic biomechanical forces. It either has to have a direct blow of the head to another object or a blow from the head to another head. Patients who have a concussion will have a rapid onset of short-lived neurological symptoms, which generally will resolve in a stepwise fashion. Now, the concussion is associated with neuropathologic changes, but these are not apparent on normal imaging, and so imaging is generally not encouraged for individuals who have concussion. Exception would be someone who has symptoms of a subdural or epidural hematoma, which we'll cover in a second. So I can guarantee you, though, that if you have an athlete, a high school athlete who goes to a football game, suffers a concussion, and the parents take him to the emergency room, there's a 100% chance that that kid will get a CT scan. And this is an issue which we'll talk about in a second about the radiation exposure from CT scans. So a useless test with a potential harm is not something that we should generally encourage. So the symptoms may or may not involve loss of consciousness. Loss of consciousness is not a predictor either of the severity of the concussion or the likelihood of an individual suffering subsequent concussions. There's a small percentage of cases, although most cases will respond within 7 to 14 days. There is a small percentage of cases where these symptoms last for a longer period of time. Treatment for those patients is different than the general treatment for a concussed athlete. All right, so here's how we identify. There are a bunch of symptoms. The main symptoms that we see are headache, somatic symptoms, a fogginess, which is probably the most common presenting symptom for a concussion. You ask an individual how they feel, they just say, well, I feel a little foggy. And they actually use that word. Emotional lability. We've had athletes who come off the sidelines and they cry like a baby. Other athletes begin anger And I've had kids who come off and they say, I don't have a concussion, I need to go back in the game. So the first thing I do is I grab their helmet so that they can't go back in the game. There may or may not be loss of consciousness. There may or may not be either antegrade or retrograde amnesia. Again, irritability is a common presentation. Patients have a slowed reaction time. This places them at increased risk for subsequent injury, places their teammates at increased risk for injury as well when that athlete's not doing their job. And these individuals can either be hypersomnolent or they can have insomnia, so all sorts of different sleep disturbances. So how do we assess these individuals? Well, the first thing you want to do is make sure they don't have a life-threatening injury, which is usually related to the neck. So you want to examine the neck for signs of bony tenderness, isolate or immobilize the neck. If you see anything like that, transport the patient immediately. Then you want to use a standardized scale to assess the individual's cognitive function. The one common one that we use is the Sport Concussion Assessment Tool, which you have a copy in your syllabus extra. These are coming out on a regular basis. There's now a SCAT 4 available. I think you have the SCAT 3. If you Google that, you can download it. There's a pocket SCAT that you can put in your wallet or in your pocket if you're covering events on a sideline. Nice thing about the sideline or Sport Concussion Assessment Tool is it allows consistency in your evaluation between athlete to athlete as well as subsequent evaluations of that same athlete. You want to monitor these individuals over the next several hours, and you don't return them to play on the day of injury. So there are no reliable prospective findings on discussing what how severe a concussion is. It's not related to the presence or absence of loss of consciousness. So we can only tell in retrospect how bad the concussion was by how long it took the individual to recover. And there's a lot of question about a really bad concussion being a disqualifying condition versus multiple smaller concussions, and we really don't know the answer to that, so that's something that we'll be following over time. So how do we manage these individuals? Well, the first thing we do is put the individual at rest. We avoid cognitive stimulation like classroom work, video games, television, all sorts of stimuli like that. No vigorous physical activity until the patient's vestibular symptoms, so their dizziness resolves, and that's an American College of Sports Medicine recommendation. Then we'll do a stepwise advance in the individual's activity, and then we'll monitor their rehab program so that if they start having symptoms, we step them back until those symptoms resolve. A little bit on closed head injury. The closed head injury demographics are basically bimodal. We have younger individuals as a result of collision sports and auto accidents. We have older individuals as a result of falls. So when these individuals have a closed head injury along with concussion, you want to look for a lucid period followed by a decline in mental function, which would indicate a subdural or epidural hematoma. All right, we're going to finish up with a few minutes on musculoskeletal imaging. We'll talk about plain films, CT, MRI, SPECT scanning, ultrasound, bone scan, and arthrography, all with respect to evaluation of musculoskeletal problems. So the most available modality we have is the plain X-ray. Almost universally available, relatively inexpensive. Very good for evaluating bony injuries, especially injuries that have happened to a degree of time in the past. You can also see soft tissue swelling, so it has some utility for that. The other thing that's important for plain films is that you can do stress studies. So if you use a fluorography machine, you can actually stress joints to see if there's laxity in ligaments. The big disadvantage, again, it's not really good for soft tissue, so other than soft tissue swelling and laxity, doesn't have a lot of utility. So here's a plain film. You can see it's an AP and lateral wrist, and you can see on the left-hand view, there's a fracture across the distal radius, and on the lateral view, you can see that same fracture with a little bit of palmar displacement, as well as a small fracture on the ulna. CT scan. So CT scan is great for bone. We often forget about using CT scans for bones, but it's very good for bone, also really good for soft tissue. Especially if you use contrast, you can see soft tissue structures very well with CT scan. One of the cool things about CT is that you can do 3D reconstructions. This is all data. You put it into a computer, you can take multiple slice CTs and create a total 3D picture. So that's nice. You can also do dynamic studies. So you can do stress studies as well with a CT scan, a little bit harder than using a fluoroscope. Pretty widely available, but the big disadvantage is the cost and the radiation exposure, a non-trivial amount of radiation exposure. There are studies that have shown that using the readily available chest CT, normal dose chest CT, increases the risk of developing a mediastinal tumor between 1 in 100 and 1 in 1,000 times, and that's an additive effect. So if you think about that over time, individuals who have concussions go to the ER, get 10 or 15 CTs over their lifetime. That's a non-trivial amount of radiation exposure. So here's a couple CTs. The one on the left is a cervical vertebral body CT. You can see through the body of the vertebral body a blowout fracture, as well as 2 fractures across the arch of that vertebral body. On the bottom right is a 3D reconstruction. This is a true reconstruction of a skull. Now we're going to talk in our emergency medicine chapter about basilar skull fractures, and this is a good way to see the basilar bones because you can flip that skull right around and look at the basilar bones. MRI, best available imaging of soft tissue. It actually approaches the sensitivity of direct visualization. Pretty widely available. There are some weight restrictions and size restrictions that are getting removed by the availability of open arm MRIs. It's expensive, and many insurance companies won't allow you to do an MRI until you first do a plain film. Or you first do a plain film and then you do physical therapy. So they're really restrictive on some of our use of MRIs. So here's a lateral or a sagittal MRI of a knee, and I want you to pay attention to the area between the femur and the tibia. You'll see a dark line that goes across there. That's the ACL, and that's an intact ACL. In our third lecture, when we talk about ACL sprains, you'll see one that's disrupted. SPECT scanning. So SPECT scanning used to be an experimental protocol looking at blood flow through exercising tissue and tumors. So it formerly was used in tumor evaluation and management. Now we also use it as an adjunct imaging method in sport. So in this case, you see the 2 positive radiology signs, those arrows. That indicates increased uptake in the lower lumbar vertebral bodies. That's actually an area of spondylolysis, bilateral spondylolysis, and this was in a gymnast. Ultrasound is a great modality for musculoskeletal evaluation, becoming more available. We actually have ultrasound machines in our 2 residency offices, so all of our sports medicine fellows are trained in using musculoskeletal radiology. No radiation exposure associated with this. Big disadvantage is you need to have some skill in both doing the procedure and evaluating it. Here's why. So here's a musculoskeletal ultrasound. Anybody tell what that is? It's an Achilles, because it says so up in the upper left-hand corner. Otherwise, I wouldn't know either. So the Achilles is the area across the top, which is those longitudinal fibers. And you can see at the left-hand or the right-hand side of the picture, there are 2 diamonds that are markers, and that's actually measuring the width of that Achilles tendon. And this is a true case of Achilles tendonitis. Bone scans are used to look for subtle changes in bone before they become apparent on X-ray. There's a 3 phases of the bone scan, a tissue phase, or a tissue angiography phase, the tissue phase, and then the delay phase. So we have to do this over time with 3 studies. It's relatively inexpensive. It's not so available because the radioactive material that they use actually degrades when it's on the shelf, so hospitals generally don't store this unless they're going to be doing multiple bone scans. So here's the 3 phases again of the bone scan. On the top, you see the blood flow phase. Left-hand side, the radioactive material, which is technetium-99M pyrophosphate, begins to concentrate in the tissue, and you can see some hot spots or dark spots in the bone of the feet. And then the delay phase on the lower right is concentration of these radioactive materials in areas of osteomyelitis in a diabetic patient. All right, arthrography, the last modality we'll talk about. This allows us to visualize joint spaces. We use contrast material injected into the joint space and then do either a plain film, a CT, or an MRI. Advantages and disadvantages for arthrography are the same as the base study, so the same as the X-ray or MRI or CT. So here's the last slide. We see MR arthrogram of the shoulder. And you can see smooth joint of the glenohumeral joint all the way around until the bottom right-hand corner area where you see a little bit of a lip or a little bit of a dog ear. And that's an inferior labral tear in this patient.